Hello and welcome to the ACR Bulletin Podcast, the show where we examine the latest trends affecting radiology. I'm your host, Chris Hobson, and today we'll be speaking with Pratik A. Shukla, MD, Interventional Radiologist and Associate Professor of Radiology at the Rutgers, New Jersey Medical School. Since July is Fibroid Awareness Month, we'll be marking the occasion by discussing an abstract Dr. Shukla recently presented at the Society for Interventional Radiology, which focused on socioeconomic disparities and referral patterns with respect to uterine fibroid embolization, or UFE. Dr. Shukla, thank you so much for being here today.
Thanks for having me, Chris.
Absolutely. Well, for those in the audience who may be a little bit unfamiliar with fibroids and UFE, can you please give us some background on what they actually are?
Absolutely. The uterine fibroids are benign tumors of the uterus. Benign is the key word there. So these are not cancerous, but benign growths that occur in the uterus in response to hormones during the menstrual cycle. As women go through their menstrual cycle over years, these tumors can grow and grow and grow. And if they're in particular locations or particular sizes, they can cause very terrible symptoms in these patients. So for example, if these tumors or masses are encroaching on the endometrium, patients can have very, very heavy bleeding during their menstrual cycle. And that you can imagine that can be pretty terrible. Some patients just have very heavy bleeding that just causes them to be uncomfortable throughout the day. But some patients will have to come to the emergency room during every cycle to get blood transfusion. So the variability of symptoms is very high. Most patients will get some signs of anemia, including shortness of breath or palpitations, dizziness, and will end up really staying in for a few days. And it's really really impedes their quality of life. Other symptoms, if the fibroids grow big enough or in the location of more outside of the near the outside of the uterus, can be of pressure or pain in the pelvis. Depending on where the tumors are pushing, different symptoms can arise. For example, if they're putting pressure on the bladder, patients can have to go to the bathroom frequently. If they're pushing on a nerve, you can have pain down the leg, sciatica or back pain. Lots of different things. So although these are benign tumors, they can have a really, really big impact on patients' lives. Like I said, they are responsive to hormone therapy. They are responsive to hormones, so they grow as you go forward in life and have multiple cycles. Once you get, after menopause, these do shrink and go away because the hormones go away. However, most women have symptoms between the ages of 30 and right before menopause. So usually they do seek treatment if they have very terrible treatment. Treatment options include anything surgical like hysterectomy, which is removing the whole uterus, myomectomy, which is having the fibroids taken out of the uterus surgically, or uterine fibroid embolization. So uterine fibroid embolization is done by interventional radiologists. It's a minimally invasive procedure that does not involve any cutting. It's not a surgery. It's all done through a small pinhole to the wrist or the groin arteries. We put a little catheter into those arteries, and the catheters are go from the artery and directly into the uterus using X-ray guidance. Once we get to the uterus and to the arteries that supply the uterus or the uterine artery, we inject dye to make sure that we can identify those arteries that are supplying the uterus and the fibroids, and we inject tiny little beads into those arteries to really slow the blood supply down to the fibroids. What happens in this scenario is the fibroids will shrink. You'll deprive them of their nutrients, and they'll become smaller and smaller and smaller over time. And once they do that, they'll take their pressure symptoms off, and they'll come off of the endometrium, and symptoms will improve. Patients will improve dramatically over 3 to 6 months. It does take some time for the fibroids to shrink, unlike hysterectomy where you take the uterus out right away. However, this is all done through a pinhole in the wrist or groin. You go home the same day after the procedure, and the risks of the procedure are very, very minimal, if at all.
Yeah, and that was my next question, actually, was what, interventional radiology has to do with all this. But I think you've given us a very detailed explanation. So thank you for that. And I guess, the part of the abstract that you all presented on that really raised my eyebrows and just really caught my attention was the fact that of the socioeconomic disparities kind of dynamic you all were contending with in that abstract. So especially particularly when it comes to referral patterns of UFE. So can you please help us understand the nature and I guess the magnitude of the problem that you all were grappling with?
Absolutely. So I'm sure interventional radiologists all across the country deal with this issue, and it's the referral pattern. So anyone that has any sort of uterine bleeding or abnormal menstrual bleeding, we'll see an OBGYN, or sometimes, very few times, a primary care first. And then typically, 99 to 100% of the patients will go to their OBGYN and get evaluated. Now, the OBGYN is the primary referral, primary referrer for this procedure, because they see the patients first. They actually provide primary care to women with regards to their menstruation. And all interventional radiologists across the country have noticed that, the referral pattern for uterine fibroid embolization is very, very small. I think less than 10% of all women that suffer from uterine fibroids actually get a uterine fibroid embolization across the country. I think the number is around 8%. And it's sort of mind-boggling, because this is one of the procedures in my field, which is a very young specialty, that's been, researched the most, has long-term data, and goes head-to-head with the surgical counterparts, especially, hysterectomy. It's very minimally invasive, has a lot, much fewer side effects or complications, and the recovery time is very, very fast. So even, in my training when I was younger, I always wondered why the referral pattern wasn't there. So when I came to work at Rutgers and here in Newark, New Jersey, the population here and fibroids are endemic to the population. Fibroids impact African American women 3.5 times more than the normal population, and Hispanic women about 2.5 to 3 times more than the normal population. And that's my community here in Newark, New Jersey. So when I came here after training, I thought I would be doing tons and tons and tons of fibroid embolization, but that was not the case. So we started to look into it and to see, to break down why we're not getting these referrals. And initially, when I started my practice, I did everything that a young budding physician does, give grand rounds, go out to different healthcare awareness programs, go to different educational sessions for patients. But what we realized at the end of the day, the referral comes from the OBGYN. And we were kind of perplexed as to why we weren't getting referrals here from our community. So the study we presented this year at SIR was, well, let's see if the patients, if the patients are choosing, because ultimately informed consent means the patient chooses their treatment based on the options that are presented to them. And so we looked at women that came to our hospital after being treated for fibroids with a surgical procedure, most commonly hysterectomy. And we had them, we talked to them and had them fill out a survey of, how do they choose hysterectomy over uterine fibroid embolization. And one thing that we was a little shocking was a lot of them didn't even know that there was an alternative treatment option. And the patients that were aware of it just didn't have the sort of knowledge of the procedure as they would have if they had seen an interventional radiologist in the office. And the patients that did have knowledge of the procedure, they were the procedure was discussed to them by the OBGYNs. Oh. So there is definitely a referral issue there. But another study that we presented a year or two ago at SIR really looked at the breakdown of the patients and how they're being referred to us. So typically an issue that, all physicians deal with is getting insurance approvals to get this procedure done.
Right, right.
So a lot of my colleagues across the country are working, even at the legislation level, to try to get insurance companies to approve this procedure as a treatment option for symptomatic uterine fibroids. But when I first started here, I saw the opposite. The patients that were being referred to me were getting approved right away, almost instantaneously. And that's not the case for a lot of other procedures. So I asked my office staff, saying, how do these patients get approved so fast? And they're like, oh, well, if you have charity care or Medicaid, the approval process is pretty quick. Wow. So that's something that really intrigued me right away. I'm saying that, most of my referrals were underinsured. So I said, well, you know what? Let's answer the question. Are we getting the predominant number of fibroid embolization referrals we're getting, are they underinsured patients, or do they represent, a normal distribution of the surrounding area? So we noticed was 80% of our referrals to my whole group was underinsured. And we defined underinsured as no insurance, charity care, or Medicaid. Right. But then I started to think, well, what if that's what that 80% actually represents the surrounding community? So we went online from the county database and we pulled the surrounding numbers. And in fact, the surrounding population was only underinsured about 35 to 40%. So we were getting a higher percentage of underinsured referrals. And I said, you know what, maybe this is unique to my community, and maybe in my hospital we're getting more of the underinsured patients. So I had a buddy of mine, go through the same IRB process and do the same exact data analysis with his patient population in a more suburban hospital in New Jersey.
Okay.
And lo and behold, their number matched the surrounding community. So that was very shocking to me. Typically, when you think of access to healthcare, you think the underinsured, they don't have access to cutting-edge, minimally invasive procedures.
Right.
But in this scenario, those are the only patients that are getting referred. And that's because I think they have to refer to a different specialty. So, I mean, we haven't answered the why questions yet, but there is definitely a disparity there. There's definitely an access to healthcare issue here, and that's something we're trying to dig into a little bit more. There's also a healthcare literacy issue that we've identified through one of my ongoing projects. So we're trying to parse out, what are the reasons and how can we improve our access, get this access to the patients.
Yeah, and that my next question kind of builds on that too. It's something you mentioned a little bit earlier as you were talking there about gynecologists and the referral patterns. I mean, that was something that came up in another article that I had read on this subject, is that in the past anyway, among a lot of gynecologists, there was a question as to whether UFE was a safe alternative to hysterectomy, or you're gonna have to help me with this word, myomectomy, I believe it's pronounced.
Yep.
Yeah, and I believe, just when we were talking just before we got started here, I think you kind of confirmed that. But I mean, have you? So you haven't got dug into the why of everything yet. You've sort of at that what level and maybe how, and maybe the how actually is this referral pattern among gynecologists. So do you have any plans at this point to have any sort of intervention with those who are referring them, or is that in the future maybe? Or
that's a great question. So that's something that us as IRs have been doing forever. We have randomized controlled data with 10-year follow-up. I mean, the Emmy trial is one of the big pivotal trials in interventional radiology. This is a procedure that's been studied, almost as much as any other procedure in IR. And the data is there. And I think the OBGYN community, in 2023 may be knowledgeable of our data. A lot of it's published in their literature, not just in the radiology and the IR journals. And on the education front, me as well as all my colleagues in the field, we do it all. We give grand rounds to different OBGYN groups. So I've given grand rounds at Rutgers. I've given grand rounds at all the surrounding hospitals that have a residency and fellowship training program. I've done CME lectures for private practice OBGYNs. Lots of health fairs and community events where OBGYNs come out. We also do educational events at those things, and we've done them, tirelessly. And there is sort of a, I've heard does it work as well? And the data is there. Yeah, it works, just as well. What's the complication rate? That's been ironed out pretty well, pretty clearly in the literature. And in 2023, it's very, very minimal, if at all. With that said, the surgical counterparts, they're getting more technologically advanced as well, but this is an option that's there. And when you present these options to patients, I think patients should, anytime you undergo a procedure, we talk about the informed consent process. And the informed consent, everyone says, these are the risks and benefits of the procedure. But the third arm of that is the alternatives of the procedure. And I think that the alternatives of the procedure should be discussed by the physician or provider performing those procedures. So for example, when a patient finds me through social media or through the internet, and they, haven't seen an OBGYN, I won't do a uterine fibroid embolization until they go talk to their OBGYN about all the alternatives and let the patient make the decision. I think that's where there's a little gap, where I think if they refer for, just an office visit or just to, chat with an IR, I think that would improve awareness of the procedure, but I can't say for sure.
Yeah, it's so interesting. You've actually answered question after question here that I had. It's so interesting just to hear you speak about this, because you're clearly animated by this issue, and you put your money where your mouth is. I mean, you're out there in the community really engaging. And it's this is one of I've been very entrenched in, population health management and health equity for the last few years, especially. This is one of the first instances I've seen, if everything bears out as build out your study here. But it seems, at least in the early going, this is one of the first times I've ever seen it where the less access, actually the higher resource population seems to be having the more access issues. I don't want to say I've never seen that before, but that is very interesting. So we'll keep our eye on that.
Counterintuitive.
Very counterintuitive.
Yeah, and I think it happens in the underserved community. So I think it's the community that doesn't have access to both healthcare, but also to healthcare education, has a lower healthcare literacy. And then another question I would get asked is, well, how are you going to increase the awareness for your patients? And one thing we have to realize is my community doesn't have access to the normal education tools that other communities may have. So, for example, social media. In business we call it marketing. In medicine we call it awareness. But the traditional awareness or marketing tools don't work here, because in my community, patients may not use social media as a tool to get healthcare education. They may not use the internet for healthcare education purposes.
Right.
And with the low healthcare literacy, that impacts their ability to even interpret the resources that they have. So actually, my group published a paper a few years back where we looked at all online education materials related to uterine fibroid embolization. So if you Google uterine fibroid embolization, the top 50 education tools that come up, whether it be university websites or awareness foundation websites or whatnot, and we did a readability study. And what that does is it looks at the website and determines how complicated are these tools to read, and it gives a grade level. So most of these online education tools were written at a grade level of 10th to 11th grade. But the average American adult reads at the grade level of a 4th grader to a 6th grader. So
gotcha.
A lot of medical writing is not written for the general public. So and it's harder in a community where you have low healthcare literacy. So to answer, how are we going to change how are we going to increase awareness? That's just something I'm trying to work on right now. I'm really trying to figure out.
Yeah, and as I understand,
been very tough in our community.
It sounds that way, and it sounds like you've been also not only all the stuff you're already doing, but it sounds like you're also working with the Radiology Health Equity Coalition, which is ACR is kind of a member of, and I'll put a link to that in the show notes. I want to make sure that we foreground your community-based work and your work with the Equity Coalition there. So,
yeah, thanks for that.
Absolutely.
I actually just just got introduced to them about a few months ago. The Radiology Healthcare Equity Coalition, they're doing some fantastic work, and they've been really receptive to everything that I have to say, and they've been paramount in helping me sort of figure out a strategy to increase awareness and education for my population. And hopefully we'll over the next few years we'll be able to come up with a strategy where we can really educate our patients.
That sounds great. And as part of that, not necessarily with the coalition, but since this episode will be dropping at the end of June as it's scheduled, it looks like you'll be leading a session at the upcoming Health Equity Community of Practice on this topic on July 11th. So maybe we'll also put in the show notes a link to that registration link. So yeah, I just want to make sure we hit all the cylinders there. So what work do you think is still to be done in this space, especially when it comes to equity and referral patterns for UFE or maybe any other discipline that, in the spaces you work in? And I guess what advice would you give to others working in this space who might be, running up against some barriers?
Yeah, I think patient advocacy is the most important thing. So people ask, well, you're busy, you have tons of other procedures. Why do you spend time on this endeavor? I've been, since I've been attending the last 5 years, I've been trying to figure this out. And I think it's because I want to be an advocate for my patient. I've had so many people come up to me that have had, alternate procedures, and they're like, oh, I didn't even know about that. I wish I had known about that. One of my family friends, out of a conversation, didn't even know what interventional radiology was. She underwent a hysterectomy for fibroids, very uncommon in the population, but it came up in conversation. I'm like, oh, did anyone talk to you about fibroid embolization? That's what I do, and had never heard of it.
Wow.
So for anyone that's in this space, it's tough. It's tough from a referral aspect, but I think that if we all just work together to figure out the root causes and just figure out a way to increase awareness to our patients, I think it may be a long journey, but I think I hope to see one day instead of 8 to 10% of patients getting fibroid embolization, maybe 30 to 40 to 50 or even more getting fibroid embolization. And there's some patients where alternative treatments may be beneficial to them, but I think the patient should have at least all the options presented to them and should be able to choose which route they want to go to.
Yeah, and it strikes me almost again, we keep bringing up this term health equity, and it seems to me like an equity issue that if you can get somebody in and out in a safe way, they can get back to work. I mean, how many of us can just take off how many days of work just to recover?
Exactly.
I mean, so some people must take that into account, and they say it's not worth it, and that's so sad. I mean, I hope that I'm with you. I hope that.
Well, that's the other interesting thing is if you undergo uterine fibroid embolization, people usually get it done on a Thursday. They're back to work on Monday.
That's amazing.
And imagine hysterectomy. I mean, yeah, patients will get back to work in a couple of weeks, but it's still more than a couple of days. And usually even longer with the surgical counterpart. So yeah, you're absolutely right. And it's definitely, I think the equity issue is definitely there. It definitely, the disease affects minorities more than the general population. Like I said, it's 3.5 times more for African American women, and 2.5 to 3 times more in Hispanic women. I think the symptom severity has been reported is also a lot worse in minority patients. So there's definitely a healthcare equity component to all of this.
So interesting. Well, I should add that there, just to build on the education piece, and I'm not sure if you're aware of this or not, but I know some people, some of my colleagues here at the ACR have been working on a patient-friendly animation on uterine fibroids. Yeah, okay, good. I see you shaking your head. That's good. There is a series on the JACR YouTube channel of because they're like short patient-friendly animations just to help patients, and it's really can be utilized by doctors to help their patients better understand different procedures. So that should be publishing soon. So we'll, if everything lines up, we'll hopefully get a link for that in the show notes as well. And I just wanted to say it's been such a pleasure talking to you. Can people, you talked about social media a fair bit today. Is there somewhere people can find you on, like Twitter, Facebook, LinkedIn?
Definitely on Twitter. Just search my name and you'll find me. It's a professional Twitter, very active. The IR community has a really strong presence on Twitter. A lot of doctors will share techniques and cases and things like that. So yeah, you can definitely find me on Twitter. For sure.
Awesome. Well, and for our viewers, if you have any future show topics, please let us know on Twitter at Radiology ACR and use the hashtag ACR Bulletin Podcast. I also invite you to check out all of our past episodes at Apple Podcasts, Spotify, Google Podcasts, and please do be sure to subscribe to ACR's YouTube channel to see our latest episodes. And please hit that like button today if you found this video valuable. Thanks again, Dr. Shukla. We really appreciate you coming on today.
Thanks so much for having me, Chris.
Absolutely. You'll have to come back in the future and update us.
Yeah, absolutely.
All right. And thank you to our listeners. This has been the ACR Bulletin Podcast. See you next time.